Hello, this is Kerry Edgar with PT Management. I want to welcome everybody to this webinar on the new physical and occupational therapy evaluation codes. Kay Hasagen, who is with LW and is a PT and does a ton of chart audits, is actually going to handle this webinar. She's prepared it. She is much more qualified to discuss this than I am. I'm just handling a couple of the housekeeping items. First, we will be distributing via email to everybody a recording and the handouts right after the webinar. So everybody will have the recording. You'll be able to listen to it or share it with your colleagues right afterwards. Also, there is a place at the right where you can submit questions. Kay has an awful lot of material to cover, so I doubt if we're going to get to your questions during this actual hour. However, we will be answering all of the questions via email, and we'll be distributing the questions and answers to everybody, regardless of whether you ask a question or not. So with that, I'm going to turn it over to Kay so she can get going.
All right, thanks, Kerry. Well, welcome to this webinar on the new therapy evaluation codes. They are going to be effective January 1, 2017. We know that we all know how to do evaluations, so we don't need to relearn that, but this coding is new. So there's been a lot of information provided already through articles and seminars, and hopefully some of you have been doing some reading, and this is not the first time you're hearing it, but we are all still working on understanding the rules and regulations and how to apply them. I'm hoping that this presentation will support your understanding of this information, and that through this webinar you'll learn the descriptors of each code and how to look at those and use those descriptors to select the appropriate code for your evaluation. We're going to look at what process and documentation changes you to support the transition and how your electronic health record templates can support your choice of evaluation codes. As Kerry said, there's a lot of information, so hang on to your seats. Be looking at the slides while I'm talking to you, and just know that you're going to be getting these in writing and also some cheat sheets to help you. So let's get started. Many of you, since we're already into December, may be familiar with these codes. There'll be 3 new evaluation codes for each discipline and 1 reevaluation code that will replace our current codes. So you can see for PT, we have 97161 low complexity, 97162 moderate complexity, and 97163 high complexity. And then the reevaluation code, which replaces the 97002, is 97164. And then the same way for OT, we have a low, moderate, high, and reevaluation code. So in the essence of time, I'm going to let you learn those, and we'll be using those for the future. As opposed to our current code, which is really a one-size-fits-all, these codes are going to be based on the complexity of both the patient's presentation as well as the your clinician's clinical decision-making. The codes will have certain components that have to be present in the documentation, and there's certain criteria for each of these components for each code. And this is the reason why this is such an important webinar, because you can't just spend a matter of time or have a certain diagnosis and have it meet a moderate complexity. You have to meet the specific components. It's been recommended that the codes have varying values based on the complexity, but CMS at this time has determined that all the codes will be valued the same, meaning they have the same pricing rate that they have through Medicare in 2016 will continue in 2017. And we're going to discuss why a little bit later in the presentation. So who do these new codes apply to? Well, it's actually interesting that it's related to HIPAA. all HIPAA-covered entities must use the current year's CPT codes. So covered entities are defined in the HIPAA rules as health plans, healthcare clearinghouses, and healthcare providers who electronically transmit health information. So this means that hospital outpatient departments, skilled nursing facilities, rehab agencies, CORFs, home health agencies, and private practices are all HIPAA-covered entities, and all of these will be required to use the updated codes for 2017. And these codes must be used not only for Medicare, but all insurers that are HIPAA entities. So that would include Medicaid, Blue Cross Blue Shield, Aetna, United Health, Cigna, TRICARE, Humana, just to name a few. Now, these other non-Medicare entities that I just named, they have to use the codes, but they can choose to value them differently. We know that Medicare is not going to change the value, but the other ones, commercial insurances, might change the value. But then there are non-HIPAA entities. These include workers' compensation and auto liability insurers. Because they're non-HIPAA, they have a choice as to whether they're going to use these codes or not. They might decide to continue to use the current 97001 and 97003 evaluation codes. So it's going to be critical that you check with your insurance carriers to determine their processes and policies regarding these new codes. So some of you might be thinking, why change? Well, CMS and the professional organizations have long been advocating for payment change, a new and updated system for therapy reimbursement. But these codes are not payment reform, but they are coding reform. However, this is important because it's the first step in the process which sets a platform on which payment reform can be made. Our current payment system pays the same for all evaluations and does not distinguish between that simple, straightforward orthopedic patient and the severe CVA with multiple comorbidities. And it doesn't give any value to the different skill levels required of the clinician in using their clinical skills and knowledge to perform an evaluation and determine an appropriate plan of care. Although these different codes are still valued at the same rate, they provide a starting point for acknowledging that there is a difference in the complexity of the patient presentation and the clinical decision making that you have to use in order to come up with the correct plan of care. These coding changes are also seen as potentially the first step to move payment from solely a fee-for-service, volume-based system to a value-based system, and could potentially lead to the payments for bundled or episodic services. Now, many of you might be familiar with the physician evaluation and management codes that have been in use for years, and they're a tiered level based on complexity of the patient. And so this is our opportunity to move towards that direction. Now, these codes were not developed in a vacuum, but it started with the AMA, who is responsible for the development of the CPT codes, and they were looking at the codes that might be misvalued, and it led them to form a PM&R work group way back in 2012. And this consisted of provider groups that were primarily using the 97,000 series of codes, which you know, those are the ones that we in therapy use. Our professional organizations, the APTA and the AOTA, were very involved in the work group, and they were charged with looking at these misvalued codes, but also with developing a reporting system that would support payment reform. So between 2013 and 2014, this group started looking at the evaluation and treatment codes and how they could shift from a time-based reporting system to one that was based on the complexity of the patient presentation. And by February of 2015, they completed the evaluation codes and their descriptors, and they set a proposed start date of 2017, and here it is almost upon us. Now, they were recommending different values for each code, and to support this, they surveyed clinicians to gather information on the utilization and the clinician time spent in the evaluation process. And then they made recommendations to what's called the Relative Value Update Committee, or RUC, if you hear that, RUC committee. And the RUC presented their information to CMS for consideration of a three-tiered system with rates that varied by complexity level. So after reviewing the RUC proposal, CMS in July of 2016, so just this past year, published their proposed rules regarding these codes and asked for input through September of 2016. Of significance in this proposal was that they did accept the tiered system of coding, but they decided to value them at the same rate. So on November 2nd, they published the draft final rule, and the final rule was published in the Federal Register on November 15th. And it's pretty long, but it starts on page 162 if anybody wants to take a look at that Federal Register. So it's been in the works, and it has been our professional organizations that are working on this. So let's talk about some of the rules for these codes, because I think it is important to understand it. CMS did not make very many changes to the proposed rules that came from our professional organizations. So when the final rules came out, they took the information from the PM&R work group and the RUC committee and instituted the following rules. They accepted the stratified codes for evaluations with a different evaluation for low, moderate, and high complexity for each discipline, and one new reevaluation code. They did not take the recommendations for the varied values, and right now all of those codes will be valued at the same rate as the current 2016 evaluation and reevaluation rates. From the proposed rule to the final rule, they made a slight increase in the value for the reevaluation codes, and one important point in the final rule was that there's going to be no changes in the 2017 Benefit Policy Manual regarding the documentation requirements. So right now, manual medical reviewers cannot use the code as a basis for denials. But all of our professional organizations are warning us that this is not going to last forever. That CMS is just allowing some time for training so that the clinicians can learn these new codes and how to use them appropriately. And at the same time, CMS is going to be gathering information on utilization trends of these codes. So this is really important for our future, that we get it right from the beginning. So why did they not value the codes differently if they're really looking at payment reform? So one of the key issues is that all payment reform must achieve budget neutrality. So their main focus was to ensure that the cost of care remained budget neutral. With the current data available, they couldn't guarantee that. So the Federal Register, they provided their reasoning behind their decision to have one rate, and you can see that their statement in the first bullet, that we do not believe that making different payment based on reported complexity is advantageous for Medicare at this time. And they were also concerned about upcoding and the pressures and incentives to therapists to upcode. So you can see their statement in the second bullet, and that's a message to us that we really need to learn how to make sure our documentation supports the coding choice that we make so that it's not perceived as upcoding in the future. And they also wanted to ensure that budget neutrality. So following the survey, the work group had concluded and presented what they determined would be percentages falling in each of the categories and proposed rates to ensure this budget neutrality. But because there was no data, the CMS was really worried about it, and they decided to hold it for right now. You might be interested to know that the PT utilization that was proposed was 25% of the evals would be in the low, 50% moderate, and 25% high, so a normal bell curve for PT. But the OT utilization that was proposed was 50% in the low, 40% in the moderate, and only 10% in the high. So of course CMS will be looking to see what that actual utilization comes out to be. And we, of course, want it to just be accurate for each patient and supported by our documentation. Before we go into the code descriptors. This is the piece that's new, and might be a turnoff for some of you, but I think it's very important to set a foundation for these codes. When you review the codes, the big thing for me that stands out is the difference in the terminology that's being used. And it is going to be important for us to understand where that terminology came from and to understand the definition of the new terms, so that when you're working with a patient and going through your routine of your evaluation, you aren't just doing the same old thing, because these the terms from this ICF are the thing that make it different and make the components, you have to understand the code components in order to choose the correct codes. So to that end, let us start by reviewing the ICF, which is the foundation on which these codes are based. The ICF is the International Classification of Functioning, Disability, and Health, and it's a framework for describing and organizing information on functioning and disability. ICF was adopted by the World Health Organization as a standard language that can be used by all to define and measure health and disability. It integrates several models of health and disabilities, the medical and the social models, and that's one of the things that I find most interesting about these code components, is that it really has a strong focus on social models. And it acknowledges that function and disability are not solely dependent on a medical diagnosis. So gone are the days where you can say, oh, this is just a knee. We have to really think that this might be a knee with some pretty hefty social issues, and then that would be a big component that we have to capture. We can't just not include that in our documentation. So we really have to think about associated health issues, the environment, and other social factors that affect the level of function and disability. Now, this schematic representation illustrates all the composite factors that integrate to determine how a person will function in their society. So in a nutshell, it starts with someone's health condition, and they have a continuum that they can have be on the good side, or they can have a disorder or a disease process and have a disability. The body functions and structures include review of their physiologic functions and their anatomical parts. And these body functions and systems can be functioning at a normal level, or there could be problems that result in a significant deviation or loss, and then they're referred to as impairments. So that's a word that we're used to seeing. Problems in body function and structure cause a significant deviation or loss and have to be documented and captured in the evaluation. Now, an activity is the execution of a task or action by an individual. So very specifics we want to see in our evaluations, like being able to go upstairs, or being able to dress themselves, or write, to fill out their checkbook. Participation is really critical here. It is the involvement in a life situation, the ability to interact or to take part in life situations, like can they go outdoors, can they go to work, take care of their pets, leave their home and visit friends, can they go shopping. So your evaluation is going to have to really play on this and think about what are the critical aspects of their participation that are involved. And then you have contextual factors that influence your ability to function. These are at the bottom, and they include environmental factors. They might be physical, social, and attitudinal environments in which people live and conduct their lives. And sometimes these can be barriers, and sometimes they can be facilitators. Like they might have a ramp, but then they might have stairs. They might not have transportation and have to use public transportation, and maybe they do or don't have family support. Those would be things that you would now be including as a significant piece in your evaluations to determine which level you're going to be able to choose. And then personal factors, which are not specifically defined in the ICF, would include their age, sex, social background, education, and profession. So there we have our overall functioning, which which is really an umbrella term for all these factors interacting with one another. And it's really the interaction between the health condition that may cause impairments in body function and structures that results in activity and participation limitations. And all of these are influenced by the contextual factors of the person's environment and personal factors. And then that sums up their ability to function within their society. So this is a really good schematic because it lets you see all of the different things that we are going to have to include, not just range of motion and walking ability or balance. Now, you're going to get some definitions, some sheets afterwards that Carrie's going to send out to you, but let's go through some of the terminology and definitions from the ICF that you need to be familiar with, and you'll see these in the code descriptors. The big ones are activities and participation, and then these relate to activity limitations and participation restrictions. So I think you might be getting the idea that these words are things you're going to be now putting in your evaluation, and maybe your electronic health record will be able to have some headers for activity limitations and participation restrictions. So the domains of activity and participation are listed, some of them are listed up here: mobility, self-care, domestic life, interpersonal, etc. If a patient has any problems in any of these areas, that can lead to an activity limitation, which would really be just a difficulty executing tasks or actions. But what you're going to have to do in your evaluation is be very specific. Like maybe they can't dress themselves, maybe they have problems negotiating stairs, and then those would be the activity limitations, and then their participation restrictions would be the cause of the limitation in the activity. So they have a difficulty participating in life situations, such that maybe they can't go to work because they can't drive their car, or they can't go to visit friends because they can't go upstairs. So those are things that you'll need to pull together in your evaluation. And as we delve more deeply into the code descriptors, you'll see the relevance of ICF and see the use of these concepts and principles when documenting in your evaluations. We're also going to find definitions and clarification language in the CPT guide, which always provides introductory language to support each new code. You know, I know you don't usually read the CPT guides, but it might be a good opportunity to take a look at these new codes. We're going to point some of them out as we go through the codes. Another big influence on the code descriptors came from the contributions of each profession's practice guidelines and frameworks. So the code descriptors are therefore distinctly different to each profession. So you'll see that the components that make up the codes have similarities, but there are also differences between each discipline. So as we talk about the PT codes, and then we'll talk about the OT codes, I don't want you to check out when we're talking about a discipline that's not yours, because I want you to be acutely aware of the differences and the setup of the components. They follow the same basic setup, so they just have different ways to describe them. So we're going to talk about the PT codes first. And as we go through these PT codes, their components and criteria, you'll see the distinct influence of the guide to the PT practice. We're not going to be reviewing it in detail today because of time constraints, but it might be something you want to review to add to your knowledge and understanding of these codes, because remember, they were really developed by our professional organizations. Here are the new PT codes. We're not going to review them again, but you will have to make sure you know these by memory: low, moderate, and high complexity. Each evaluation code must include these 4 components. And this is thinking about your way you do evaluations now. Probably most of these things are incorporated, but they're going to be very distinct now in order to determine which code you're going to choose. So thinking about how your electronic health record or EHR is formatted, maybe there's opportunities to have these as titles so that you don't miss one of them. So depending on the complexity level, each code will have specific criteria under each component. So the history includes the medical and functional history and any comorbidities or personal factors. Then you get into the examination, which is where the assessment and review of systems begins, and our standardized tests and measures. This is our hands-on evaluation. And these two components, the history and the examination, are equivalent to the exam portion of the PT eval that's noted in the guide to the PT practice. The clinical presentation of the patient, this is kind of where our assessment comes in. It looks at the overall patient's condition, and we want to focus on, is the condition stable, is it uncomplicated, or is it progressing as expected, or is it unstable, unpredictable, or evolving. And then we have our clinical decision making, where we analyze the data from the history and examination to determine the plan of care and outcome. And this is, according to the guide to PT practice, the evaluation element of the PT eval. Notice that there is an AND, A-N-D, after each of the components, and this is because all the components must be met for a code to be selected. You can't just choose one or two that have the highest level. You have to meet the criteria in all of the cases in order to get the higher level of code. So let's take some more time to clearly define each one. And the good news is you'll have these slides afterwards so that you can use them as some guidelines. And it would be great to take some of your current evaluations and see, are you meeting this criteria? So under the patient history, we have all past and current medical history, comorbidities, previous functional levels, past treatment, social history, and living environment and personal factors. Now remember that the key factors in the patient's history that can be used to determine the code level are only those personal factors and medical comorbidities that may influence the patient's participation in therapy at this time and their ability to progress and meet goals. So you don't have to put their whole life history down, but only the things in each of these bullet areas that are important and will have an impact on the plan of care that you want to put together. So the CPT introductory language in the CPT guide defines personal factors, which are a key part of the history for both PT and OT. The introductory language defines it as these things that are on the slide. Again, it's important to remember that we can list many personal factors on our evaluation, but only those factors that will impact the patient performance or the plan of care may be considered when selecting the level of evaluation. So that's where it's going to be important for you to connect the dots as to why is something that the patient says about their social background important to the way you think that they're going to meet their goals. Comorbidities are additional diseases, conditions, or disorders that, along with the primary disease or disorder, may impact the patient presentation. Now, they don't always have to be medical or physical, as noted here, but they can be cognitive, socioeconomic, cultural, environmental, and patient behavior characteristics. So you can see in the example, like obesity might be a comorbidity for someone who had a total knee replacement or total hip replacement. But if we don't ever think about what their BMI is, and do they qualify for obesity based on their BMI, we might not include that. So these are just some ideas of things that we might not have thought about to include, but we will now. On to the examination. This is our hands-on assessment, and the important thing here is that we want to use standardized tests and measures. It's part of the criteria that must be met. So you want to do your physical assessment of your body structures and systems and relate any impairment to their effect on activity, and remember how it affects their participation. So when you, this is, I think, maybe a little bit of a transition from our typical just get in there and take the range of motion and set them up on a program. because you really want to think about how those activity limitations will affect participation in life situation. So that will be how we'll be writing our goals, thinking about those activity limitations and the way they restrict participation. So if you have someone who has contractures, you of course would take their range of motion and muscle weakness and their manual muscle test. That would be their body structure and function. But then their activity limitation would be difficulty walking and dressing, and their participation restriction would be their ability to return to work. And that's how the language and terminology under the ICF works. Here's some further clarification in the CPT introductory language. They define some body structures, regions, and body systems, which you can see on the slide. And we're not going to spend a lot of time on that because it is something that is familiar to us, but it is important to remember that the ICF has some different nuances. We must note that the body systems are the ones that are on the slide here are ones that are most frequently impacted by therapy, but there are other systems depending on your practice area that could be added and included. It's important to know that the CPT introductory language notes that the body systems review does not only address the physical aspects such as range of motion, strength, and etc., but also the cognitive and psychological and behavioral aspects of the patient. Their level of ability to make their needs known, their level of consciousness, orientation, learning preference. So when you're reviewing your body systems, make sure that you aren't forgetting any of these things. Even if you think the person is pretty with it, we need to make sure we check it out. And this might be an opportunity to have these things more clearly on our electronic health record. So now we've gotten all that information, we're looking at a more holistic approach of this person, and we're going to stop and say, wow, what is the clinical presentation based on their physiological responses? We're going to include things like pain, swelling, blood pressure, pulse, sweating, neurological signs. We're going to take into consideration things as fluctuation in pain, results from our tests. Do they change? And what's their response to activity? Do they have frequent acute episodes with unpredictable responses? Are they having resolving pain, swelling, and symptoms, or are they having unstable medical conditions? I was doing an audit yesterday, and the patient was having cardiac problems. I mean, those things are going to greatly affect the way you treat them and their outcome. They need to be captured. So this is going to be a big part of the clinical presentation of the patient. And the fourth component, our clinical decision making, this is showing our value as skilled clinicians. We have so much education these days, we really need to be able to capture it and demonstrate it. So we're first performing our focused examination and then using our clinical knowledge to take that data and make clinical decisions related to the plan of care and ultimate outcome for our patients. So here's what you look at each case and determine, do they fit into a clinical pattern or a clinical practice guideline or care process? Are there multiple treatment options available? Or are there multiple aggravating signs and symptoms that are unstable and may influence their interventions and outcome? The composite of all these factors from the history examination and the patient presentation culminates in this analysis. So it's not just a diagnosis that's used for this clinical decision making, and that's definitely one thing that we have to get away from. We can have a protocol for a total knee replacement, but we can't just fit every patient into that because they might have other factors. So all these decisions should be made and supported by the best possible current evidence. Now, one thing you're going to see when we look at the specific code descriptors is that there are times for each code, and they're referred to as typical times. This is just the time spent face-to-face in front of the patient and or family during the evaluation process, so it doesn't include any of your documentation time. And the important thing to remember is that these new codes are not timed codes. They remain service-based codes, just as our current evaluation code was. And the typical times are just guides used in determining value, but it's not really directly related to determining the code level. So you could spend 45 minutes on a low complexity. Wouldn't be very effective, but the typical time does not make the difference. So here are the typical times by discipline and code. Now you can see that there are differences between PT and OT, and many have commented and questioned as to why the OT typical times are greater. And this was just the results of the information gathered by the work group when the clinicians were asked to determine their time for clinical work for each of the level of evaluations. It doesn't have anything to do with the value of the discipline. So let's go on to the descriptors for the PT. This is a low complexity, and this patient would be someone that has no personal factors or comorbidity that's going to impact their treatment. The clinician will be addressing 1 to 2 elements of their body structures, function, maybe range of motion, strength, or the Berg. Their activity limitation might just be limited, can only walk 1 block, and their participation deficits are that they can't return to work as a postman. So the presentation is very straightforward. They have no instability. They're progressing at the expected rate. There's no complications or outside impacting factors. There's definitely limited data to review, and it's a very straightforward decision making as far as the course of treatment and intervention outcomes. For those of you who met me previously, I did have my total knee replacement 2 weeks ago yesterday, and I had my first outpatient evaluation yesterday, and it was definitely low complexity. Thank goodness. So that's a real simple one, and we're still going to have a lot of these patients. Now let's get into a moderate complexity. You can see that all of these different buckets, remember we talked about the 4 specific components that have to be included in your evaluation, and your documentation has to support those 4 components very clearly. You're going to have a patient with moderate complexity. They're going to have relevant personal factors and comorbidities, and at least 1 or 2 that are documented that affect plan of care. So if you leave out that that person has some obesity based on their BMI, you might miss out on a moderate complexity just because you didn't put that into the history. You have to, when you're examining and addressing that there's 3 or more areas of body structure or function, activity limitations, or participation restrictions, and the patient is not stable. They're changing and evolving. So you might miss out in your documentation of putting that their pain level is really fluctuating. You might not think it's a big deal, but it could be the deciding documentation factor that makes this person a moderate complexity if they have meet the criteria in the history examination and clinical decision making. The patient is no longer stable. They are changing and evolving, and you have to analyze more data. Maybe you do additional tests and measures, and you have to consider varied treatment plans and options. So you might put in your plan that there are some variations. So that would be your patient who's moderate complexity. When you go to the high complexity, your patient has a more complicated medical history. There would be 3 or 4 personal factors or comorbidities that would impact care. You might have your electronic health record be able to capture these, like say in red, so that it would be quickly able to count up and say, oh, I did have 3 things that I documented in history, and I had 4 things in my examination. And you can review what you documented to see what code you're going to pick. You would have 4 or more elements that might be included in the examination, and they would definitely show that you had an increased use of standardized tests and measures. The condition would be unstable and unpredictable, and there would be more data to analyze. the treatment options are more complicated to address all of the associated influences. Now here's the PT reevaluation code, and it is 97164. To use this, there must be a significant change in the patient's presentation that would impact the outcome to warrant a reevaluation. So the reasons for using reevaluations in 2016 are stopped on December 31st, and this is the new definition that you're going to have to learn. So when you do a reevaluation, you have to include an examination that has a review of history, and it uses standardized tests and measures, and it is required that there's a revised plan of care based on the patient assessment. When you use the reevaluation code, you have to understand that you can only choose this when there's already an established, ongoing, current plan of care. So say a patient was discharged like 2 weeks ago, and then the doctor sends him back again for therapy. Even if there's a short period of time like that, you can't just do the reevaluation code. You have to start with a new evaluation if there's no active plan of care already. But say you have a patient who's still on, you haven't discharged them, they go to the doctor and they have something else that has happened, maybe gives them an injection and wants you to do something different, you then could do a reevaluation and revise your plan of care. So that's going to be a slide that you might keep out and pay more attention to. Let's move on to the OT codes. And as with PT, you're going to see some of the terminology of ICF and some introductory language provided by the CPT guide that will help us understand the new terminology. Even though the OT codes are different than the PT codes and the components, I want the PTs to pay close attention because the setup and the thought process of the things that go into the evaluation are still very similar. The main influence on the codes for OT is the OT practice framework. And again, we're not going to be reviewing the framework in detail due to time, but it would be in your best interest to review that framework as you develop your comfort level with understanding and using these codes. And here are the OT codes that you will be committing to memory soon. Let's begin the review of the OT evaluation codes. So as with PT, the OT evaluation codes have basic components that are part of the codes with criteria for each component varying according to the level of complexity. You'll see that the OT codes have 3 components as opposed to 4 components of the PT. And you'll see that there are distinct differences based on the discipline's practice framework. When choosing a code for every evaluation, the OT has to consider the history, which includes their occupational profile and medical and therapy history. And then the patient assessment is the hands-on observational assessment, and it includes the assessment of the patient's performance in different areas of occupation. The clinical decision-making is the 3rd component, and the clinician will review and analyze all the data from the occupational profile, history, and assessment to determine the plan of care and outcome. So, basically, you might be saying, what's the big deal about this? Because that's that's the way we do our evaluation. But I want to stress that it is very critical that these components have to support the level of code that you're going to choose. And they have to be very specific. So again, your electronic health record might want to have highlights for these specific areas. There are definitions, again, for the OTs that came from the OT practice framework. This is always the initial step of an evaluation and tells us truly who that person is. It sets the foundation for the assessment and development of the plan of care, the goals and outcomes that are client-centered. So that occupational profile includes information about the client and their needs, problems, and concerns, about how they're doing and performing. It's not just your typical prior level of function where one indicates independent in ADL and lives in two-story home with bedroom, bath on the second floor. It's more the patient's role. Like maybe they're a wife or a mother or a grandmother. What are their interests? What are their habits, daily patterns, and values who make them, as they are, a real person? And occupational performance includes all their skills: motor, cognitive, sensory motor, psychosocial. These are needed for the patient to be able to do the things that are part of their role and their occupation. And then the third part is the analysis of their occupational performance, which focuses on collecting and interpreting information, using assessment methods to observe, measure, and inquire about aspects that support or what kind of barriers are there to their occupational performance. During this process, the patient and the clinician can identify what are the priorities and what are the needed outcomes to ensure maximum participation. We've already reviewed the definition of the occupational profile, so we can quickly go through this slide and notice that the history needs to include the therapy history and also past issues. We want to really paint the picture of who this patient is with the occupational profile and history, which is the first section. The second component is the patient assessment, and this is the area where you need to identify and assess the performance skills that may need to be addressed. These are the skills that each of us possess to be able to do the activities that allow us to participate in our occupation. They include physical skills that might refer to their body structure or function, like balance, mobility, strength, endurance, etc., but also their cognitive skills. Can they think, understand, problem solve, sequence, remember things, and how can they interact with their environment? Psychosocial includes coping skills and habits, and performance deficits. What activities is the patient experiencing difficulty in? So you're going to use your standardized tests and measures to help define the level of deficit that they have. So there's some very specific definitions of performance deficits that I'm going to let you review. The CPT guide uses these terms and has these definitions. So I think that they are important to make sure you are aware of them and you can take time to take a look at them more closely. The third and most important component of your evaluation will be your clinical decision making, and this is where we can demonstrate the value of our profession and all that education and experience that we have. This is where the OT uses their clinical knowledge, experience, and skill to analyze the deficit areas and come up with the targeted goals and outcomes. And with clinical decision making, the clinician will take into consideration the amount of factors needed to be reviewed in the medical history and their occupational profile, as well as the extent and complexity of the analysis of data from tests and measures. And they will come up with their plan of care and the number of short and long-term goals that they need. So let's take a look at the OT low complexity. This is the 97165 code, and in order to choose this one, you would have a patient with a very brief occupational profile and history, and there would be no real impact on the presenting problem. There's 1 to 3 performance deficits that result in activity limitation, and the clinical decision making is very problem focused, and there's not many contributing factors. So you might be thinking like, wow, a lot of our evaluations are going to fall into this low complexity because of the things that we see. So, and that's okay. It's just important to be able to capture what if you do have a moderate complexity. You don't want to miss it. So here we are looking at the moderate complexity evaluation, and we definitely see that we have expanded contributing factors, and there may be personal factors or comorbidities, 3 to 5 performance deficits that result in activity limitations. You might have to be creative, and that might take some time to pull it out of the patient as to what kinds of limitations they're actually having at home or at work. And The clinical decision making, again, is more complex because they have there's more data to analyze from the occupational profile, history, and assessment. I know you're all thinking about some patients that are really challenging, and it takes you a lot longer to pull out their history, and it is really complex. So this is a great opportunity to be able to capture that in your moderate complexity. And of course, your high complexity is again going to have even more descriptors and 5 or more deficits that result in activity limitations or participation restrictions. You're going to have more standardized tests and measures, and your clinical decision making will be at a higher level. And we will have, again, significant adaptation or assistance needed for the patient to participate in the evaluation process. As with PT, there's a single reevaluation code for OT, different code 97168 for OT. It's used if there's, again, a significant change in the patient's presentation. Just like for PT, to qualify as a reevaluation, there must be an assessment of the functional or medical changes. And this one has to have an updated occupational profile with changes in the condition or environmental or personal factors, and you would revise the plan of care. Again, just like with PT, you have to have an existing plan of care in place in order to bill for the reevaluation code, and you have to meet all of these criteria. Well, it would be nice to spend some time applying these principles to some patient scenarios, but in the essence of time, we can't do this today. But I do think it's important for us to remember that this is new information for us, the way it's put together, and we have to learn the new terminology and the new definitions. We're working with these codes for the first time, and we want to use them and interpret them correctly. We might have differences of opinion for the choices of codes for each evaluation, and we should always welcome discussion. But we must remember that as the evaluating clinician, you ultimately make the final decision, and you have to take ownership of that decision and take the responsibility to ensure that your documentation supports the choice you make for your evaluation. So you need to have all those components in there. I urge you to begin thinking about these new applications that as you're completing evaluations now. And in order to assist you, I suggest printing the following, I call these cheat sheets. So there's one for PT and one for OT. So this kind of takes it, puts all 3 of them together so you can see the comparisons, and you want to really look at these and use these and compare and see as you're evaluating your patients, do you have these factors? And remember, in order to choose a moderate, you can't just have one from the moderate level and the rest are in the low. That person would be a low. In order to have a moderate, you have to meet all of them in the moderate. So there's the one for PT, and here's the one for OT. And Carrie will be sending these to you as attachments that you can print out and you can use when you're taking a look at your current evaluations and as you're evaluating your EMRs. You know, these new codes and their descriptors shift the emphasis on patient presentation and clinical decision making rather than just the time or event of the evaluation. It really begins to move us away from classifying patients by their diagnosis, but rather their overall presentation. It acknowledges that each patient is unique and brings to the table their own set of personal, social factors, comorbidities, and specific needs. For the first time, these codes recognize that there may be different levels of clinical decision-making involved, and it puts values on this skill set. And even though right now the rate that we're getting reimbursed is the same, we really want to put a lot of focus and energy into making sure that our documentation can capture when we have a moderate or a high complexity, and make sure that when we know that we're going to have some changes in our pricing, that we can capture that too. So this really is the beginning of a move towards value-based and outcome-based payment system. So, the evaluation process really remains the same. For both professions, even though there's different terminology, we need a good history review, examination of the patient, and then analyze all that data to lead to the development of a plan of care that will give us our outcomes. And that's really no different than the evaluations we're doing now. But the things that are changing is that before we do our evaluation, we have to know the descriptors and the components of each code so we can make the right choice. After the patient leaves, it's too late to ask them, oh, dang, I should have gotten their weight. I should have, this doesn't take long to calculate a BMI. Like maybe you need to have a BMI calculator, on your apps or, a little printout list so that you can include some things like that. Like you want to just capture everything you possibly can. You also want to understand that these components are not the only area that we should be evaluating. We want to do comprehensive evaluations so that we can provide high quality care, and we want to make sure that we're making our choice not just on the diagnosis or on a chart review, but remember to choose the code as you finish your evaluation and not before it. Some considerations for documentation. As with all of our documentation, the documentation for our evaluation has to support the code of choice. We do expect that we will be doing audits on whether the documentation supports the code that was chosen. Remember, we talked in the beginning about CMS's concern about upcoding. So just know that that's probably coming down the pike. It will be coming down the pike. You as the clinician must choose the clinical information that you document that will support your choice of an evaluation code. So there are aspects of your documentation that can assist you, like make sure you have the appropriate ICD-10 codes to support comorbidities. That will be helpful in painting the picture of your patient. It's also important to make sure you use a lot of objective measures. Instead of writing generic, like within normal limits or within functional limits, it shows in objective terms that progress is being made with our intervention and shows the value of our services. The performance deficits, impairments, and activity limitations and participation restrictions that we document in our evaluation should guide us in developing our goals and intervention as they have identified for us the areas that need to be addressed with therapy. Just listing comorbidities and personal factors is not going to be enough. We need to document why and how they'll impact the patient and their course of therapy. So I like to think that this is really a challenge for the therapist to think. There's a lot of electronic documentation where you can click off a running list of comorbidities, but that doesn't increase the complexity of the patient's presentation if you don't connect the dots of how those comorbidities relate to their activity limitations and their participation issues. So you want to consider your narrative, when you document justification of skilled services, to paint that picture. When we audit evaluations, we often see running lists of impairments and what could be performance deficits. Those could really be part of care, but we often see them just listed as a reason for referral or justification for skilled therapy instead of a focus of having them be an integral part of the care plan. So we want to make sure we really tie together the patient's comorbidities into their ultimate outcome. We talked a lot about painting that picture. Your documentation should help a reviewer visualize this patient, their deficits, their presentations, where they were prior to your intervention, and what you'll be doing with them. And your intervention should show where you expect them to be once you've completed your therapy program. You want to say specifically what things they will be able to do. You want to be as patient-specific as you can. Try to stay away from generic statements. You don't want to say return to prior level of function or improve quality of life. You want to document what they need to be able to do to return to their prior level or to improve quality of life. Like they need to be able to transfer independently. They need to be able to go out so they can go out with friends. They need to be able to lift 50 pounds in order to be able to return to work. So be very specific. And your electronic documentation can be changed to accommodate these changes, which will help with efficiency, but don't forget to still ensure that you're not using just generic statements and lists repeatedly and robotically. Use it as a guide to you to make it patient-specific so you can really paint the picture of that patient. So I hope you're asking yourselves, what do I need to do with all this information? Wow. Well, you want to use it to learn the descriptors and the criteria for each code for your discipline. Take your cheat sheet and practice with your current patients. Like review your current documentation and decide from this evaluation what code would you choose. You know, have you included the required components for your discipline in your current evaluations? Or you might decide, wow, I think this patient really is a moderate complexity, but based on what I documented, it's only low. So what do you think you could have added to make this documentation support a higher code? And that's not upcoding. That would just be documenting appropriately. So there are things in those components that we maybe are not used to using and looking at. So will take a little bit of time to rethink and retrain yourself. They say it takes 3 weeks to make or break a habit. So here we are on the beginning of December. So this is going to start on January 1st. So I'd say if you start now, you might have some changes in your behavior of the way you document your evaluations before you start using the new codes on January 1. So you might want to do a lunch and learn session within the department to be able to share opinions and help each other problem solve and analyze each case. But definitely need to practice, practice, practice. I've included some resources for you so that you can take a little bit of more of a look, and that about wraps up all that information that I have to share for you today. Carrie, are there any questions that we want to take? I think we have maybe a couple more minutes. I also want to say that there are some references here that you can also look at.
Yeah. Kay, we do have a couple of questions, but we are already past the hour, so we will answer those questions. We'll put together an email with the Q&As, not only of this session, but the session a week from now, which is a repeat, but we should get different questions then. Everybody will get a copy of all questions and answers. And also we will again be sending out a recording of this webinar and all the handouts to everybody this afternoon or no later than early tomorrow. So I want to thank everybody for joining us. We would appreciate very much if you took just a couple minutes and answered the survey that you're going to get that helps us with any sort of future webinars that we may offer. I wish everybody a great afternoon, and again, thanks for joining us. Bye now.